Hello, Holistic. Our topic today is anti-inflammatory drugs. These are the objectives that we'll be going through today. History, uh, it was aspirin was first synthesized in a pure form by Felix Hoffman in 1897. Total pain is a term coined by Dr. Cicely Saunders. Um, Both physical and non-physical causes of pain. As far as physical, there is the inflammatory component of the pain that we are focusing on. Inflammatory pain is defined as increased sensitivity due to the inflammatory response associated with tissue damage. In the WHO analgesic letter, which was put forward in the 80s for basically chronic cancer pain, you'll find the non-opioid is in the 3 steps here. Step 1, step 2, and step 3. The non-opioid basically constitutes the paracetamol and the rest of the NSAIDs. Um, I want to mention something here, just to kind of as a reminder. Paracetamol is an NSAID, but we usually put it in a separate category because it has different characteristics than the rest of the NSAIDs, and we're gonna get into that at the end of the lecture. Pain management is multimodal. You work on the transduction, you work on the conduction, you work on the transmission, you work on the modulation, you work on the perception, and you work on the CNS responses. So, for example, NSAIDs work here on the transduction here. We'll start with steroids. Steroids work inside the nucleus. So the steroids comes from outside, and then it basically, go through the cell because it's a lipid soluble hormone, and then go inside the nucleus where it's activated to a receptor hormone complex that alters the gene expression. And thus, a newly formed messenger RNA is developed, which directs the synthesis of specific proteins on ribosome. And then ultimately, you will have the new proteins altering the cell's activity. Corticosteroids inhibit the phospholipase A2. Remember, NSAIDs work only on the cyclooxygenase, while corticosteroids inhibit both the lipoxygenase limb and the cyclooxygenase limb. And thus, it's useful in patients with, asthma, for example, bronchial asthma, because it's inhibiting, the lipoxygenase pathway. Corticosteroids, in a nutshell, suppresses T cell activation, suppress mast cell degranulation, reduces capillary permeability by inhibiting basophils and mast cells, reduce prostaglandins and leukotrienes by inhibiting the phospholipase A2. Steroids play an important role in pain and palliative care. All of you guys are aware that steroids is important to reduce the bowel edema and malignant bowel obstruction. Large vessel edema, like superior vena cava syndrome, and so many other, indications, including hepatic capsular distension. Okay, so this is an important one that we see a lot in palliative care. As far as pain, it can be very helpful in rheumatologic diseases, spine pain, intractable migraine and brain mets, spinal cord compression, shingles, and it could be an adjuvant with nerve blocks. We do this all the time. We add dexamethasone to our local anesthetics while we're doing our blocks to prolong the duration of the block. Steroids are classified either short-acting, intermediate-acting, or long-acting, also classified based on its mineralocorticoid potency versus glucocorticoid potency. For example, hydrocortisone is 1-to-1, mineralo to glucocorticoid potency, while a drug like dexamethasone is mainly glucocorticoid, in potency here. Glucocorticoid adverse effects are minimal with the long-term physiologic glucocorticoid replacement, and also with short-term supraphysiologic dosing. However, studies have shown that side effects are associated with cumulative and average doses in a dose-dependent fashion. Most common side effects are weight gain, skin bruising, sleep disturbance, mood symptoms, cataract, acne, and fractures. As far as fatigue, in fact, actually, glucocorticoids often help relieve the fatigue symptoms. As far as the systemic side effects, glucocorticoids can cause indigestion, heartburn, increased appetite, and weight gain. A lot of times I put the patients on PPIs, especially if it's a long-term, steroid intake, or if the patient has a history of some sort of a gastropathy here. Acne, headaches, dizziness, heartburn, mood changes. I always warn the patients about the mood changes when they get the steroid. Reduced libido and difficulty sleeping. Steroids can also cause adrenal suppression, cataracts, glaucoma, immune suppression, muscle wasting, bone changes, and such as osteoporosis and fluid shifts. Steroids, in a nutshell, here are drugs that can have various effects on body depending on the dose and duration of use. Local side effects upon injection, such as post-injection flare, and this happens in 1 to 5% of the patients. And we usually like to add local anesthetic, when we do our injections with steroids to reduce the incidence of post-injection flare. Skin depigmentation and subcutaneous atrophy can happen if the steroid is basically leak underneath the skin, in the subcutaneous area. It's not a major complication, but for cosmetic reasons, people do not like it. Bleeding, bruising, steroid shock, and soft tissue calcification can happen. If you repeat steroid injection in a joint, you can have steroid arthropathy. And also, if you inject it in a tendon, you can lead to a tendon rupture atrophy. All right, we'll jump into the NSAIDs. The NSAIDs work on, inhibiting the cyclooxygenase enzyme, the COX. COX-1 is primarily responsible for prostaglandins involved with housekeeping functions, such as gastric cytoprotecting effect, renal vasodilatation, and vascular hemostasis. COX-2, which is in the inflamed tissue, appears to be the isoenzyme responsible for the regulation of the inflammation. COX-2 selectivity varies from aspirin to celecoxib, which has more, COX-2 selectivity versus aspirin, which causes irreversible inhibition of both COX-1 and COX-2. I got a kind of updated picture for NSAID selectivity. You see here, the more right you go right, the less selective it is. And if you go left, the more selective you are. So you see here celecoxib, for example, meloxicam. Etidolarc is a very good choice. Okay. Again, I show you this picture at the beginning here. Steroids work on the phospholipase A2. Okay, the NSAIDs work on the cyclooxygenase enzyme that basically causes the arachidonic acid to bring the prostaglandin H2, which is basically go to three pathways: prostacyclin, prostaglandins, and thromboxane. The thromboxane basically is the one responsible for platelet aggregation vasoconstriction, while the prostacyclin is the one responsible for reduced platelet activation and vasodilatation, while the prostaglandins E, F2, alpha, and D work on the smooth muscle control, inhibition of the gastric secretion, hyperalgesia, and renin release. I would like to put forward the classification of NSAIDs according to their chemistry here. So we can divide them into 8 categories. I would like to keep paracetamol out of this, group of drugs, but I'm gonna keep it as an NSAID, okay? Because it will confuse you, or if I'm talking about NSAIDs, I'm talking about all the NSAIDs except paracetamol. We're gonna talk about it separately, okay? Because it's really different than the rest of the drugs here. We have the carboxylic acid, such a group such as aspirin, propionic, such as naproxen, acetic acids like diclofenac, solindac, etidolac, enolic acid such as meloxicam, piroxicam, lonoxicam, antranilic acid like mefenamic acid, also naphthyl acetic acid prodrug such as nabometone, relevant. Then you have the COX-2, selective drugs such as Celebrex or celecoxib, parecoxib, dinostat, etoricoxib, alcoxib. And then lastly, and we're going to talk about it separately here, as I told you, is the paracetamol. Now, aspirin is a very important drug for, as a blood thinner, but you can use it also for migraine headache, okay, especially if you combine it with acetaminophen. But we don't, also for fever, can be used, but we don't use it really for pain and management per se, okay? Now, I like to add it to the other regimens, especially if I'm gonna use long-term NSAID in a patient, and this reduces the risk of, thromboembolic complications. Okay, propionic acid, naproxen, and ibuprofen, one of the most famous NSAIDs used. The naproxen, in particular, is useful in cardiac patients. Oxaprozine or Dapro is a good drug, but it can give you false positive results in urine drug screening as a benzodiazepine. So be careful about this. If your patient is using it, he might show up positive for benzos. Okay, diclofenac, unfortunately, this is one of the most commonly used NSAID all over the world, and unfortunately, it can cause arrhythmias, especially in elderly folks, and can cause also liver toxicity. Etidolac is a relatively benign drug, and it has a good COX-2 selectivity here. Piroxicam is also a relatively selective drug, and we use it extensively. Piroxicam is an old drug, but still used. Lernoxicam is similar to meloxicam, but it can be given intravenously, and that's the main advantage. Mefenamic acid is useful mainly in ministerial type of pain. Okay, naprometone is a product that doesn't irritate the stomach like the rest of the NSAIDs. It's I used to take it myself in the old days. It's really good, but it's really a large tablet. For some reason, I remember the thing that irritated me the most. It was like a huge tablet here. Um, then you have the COX-2 inhibitors, Celebrex, Parecoxib and Etirocoxib, and these are useful NSAIDs, especially with patients that have GI, issues like gastritis or peptic ulcer disease and so forth. Then you have the paracetamol, and in fact, it works on a COX-2. Okay, according to our knowledge up to now, but it doesn't have a lot of anti-inflammatory effect, and unfortunately, it can cause liver damage if it's taken in large doses. And we'll be talking about it separately later on. So we're starting with the salicylates. As you see here, we have the aspirin, the famous aspirin, the 81 milligram for protection of secondary prevention of cardiovascular disease. And then we have here the choline magnesium trisalicylate. By the way, these are good drugs, but unfortunately, not a lot of people are acquainted with them. Now, these are the ones we just mentioned. The naproxen, Advil is ibuprofen, and oxaprozine or Dapro. And this is the one that give you false positive results for benzos. Ketorolac is a famous drug that we use for postoperative pain. We use it also for intractable migraine. Unfortunately, it causes a lot of GI irritation, and that's why we use it in a limited amount. Okay, maybe 3 days or so, 3 to 5 days, not more than that, because it can cause a lot of GI irritation. While its cousin, basically Etidolac, has a better GI profile, and it's you have the tablets here from the Etidolac that you can give to your patients, and it has a high COX-2 selectivity. Then the diclofenac, sodium and diclofenac potassium, and as I told you, these are very effective drugs, but unfortunately, they can cause arrhythmias, especially in elderly folks. And sometimes, in rare situations, they can cause liver toxicity. Lernoxicam, you have the tablet form, You have the IV form. Piroxicam can come in the IM form, which is Feldin, a very old drug. But again, it causes a lot of GI irritation. Meloxicam tablets, and it comes also, in a IV form. Meloxicam is one of the highly selective COX-2 drugs, COX-2 inhibitors. Nabometone, which, as I told you, it's a prodrug that has very little GI irritation because it's a prodrug. It gets changed inside your body. Mefenamic acid is mainly for menstrual problems, menstrual pain type of deal. Okay, and these are the COX-2 inhibitors. The recent update here is the Parecoxib. The Parecoxib or Dynastat is a IM or /IV COX-2 inhibitor, and in fact, it has the same potency like basically ketorolac, with more selectivity, of course. Okay, the NSAIDs pharmacokinetics. The majority of NSAIDs are present in their ionized form and highly bound to plasma proteins such as albumin. This results in volume of distribution between 0.1 to 0.3 liter per kilogram, which approximates to the plasma volume. The high degree of protein binding makes them susceptible to displacement and consequent alteration of the kinetics of other highly protein-bound medications, such as Coumadin. So the main issue is they displace other drugs from their protein binding. Decreased protein binding due to renal failure or hypoalbuminemia may increase the volume of distribution of the unbound fraction of this medication. NSAIDs undergo significant metabolism by oxidation and glucuronidation catalyzed by the hepatic cytochromes, with only minor excretion in the urine as unchanged drug. Aspirin is rapidly metabolized in the liver to salicylic acid and then conjugated with glycine to form salicylic acid. Aspirin or acetylsalicylic acid urinary excretion is highly dependent on the urinary pH, ranging from 85% with alkaline urine to less than 5% with highly acidic urine. So basically, if you want to get rid of aspirin or acetylsalicylic from your body, you need to add an alkaline like sodium bicarbonate. All right. Principal adverse effects of NSAIDs. As far as the GI goes, dyspepsia, peptic ulcer disease, diarrhea, gastrointestinal hemorrhage, kidney-wise, renal dysfunction and failure. It can cause acute papillary necrosis, chronic interstitial nephritis, decreased renal blood flow, decreased glomerular filtration rate, salt and water retention. Inhibition of platelet aggregation, increasing the bleeding time. Altered liver functions and jaundice. Drug interaction, impaired cartilage repair, and osteoarthritis. And these are some of the drug interactions here. Please take a note of this slide. NSAIDs drug interactions can increase the anticoagulant activity via displacement beside impairing platelet function. NSAID inhibit renal elimination of lithium, which can lead to elevated serum lithium levels. Lithium, we use it in bipolar disorder, basically. NSAIDs can cause fluid retention, edema, and modest increase in blood pressure that can interfere with antihypertensives and diuretics. NSAIDs inhibit tubular uric acid secretion, antagonizing uric effect of probenecid. So don't give it with probenecid. Tempter triad, okay, basically is one of the immune effects of acetylsalicylic acid, which is a triad: sensitivity to aspirin, asthma, and nasal polyp. Also, NSAIDs can cause, anaphylaxis, hives, respiratory distress, low blood pressure, and so forth, swelling of the lips and tongue. Anaphylaxis is related to, a hypersensitivity reaction type 1, which is basically, mediated through the IgE, which is released by the B cells. And then this kind of start to cascade of releasing of different mediators through the mast cells or basophils. And usually anaphylactic reaction is after, after one exposure. It doesn't have been from the first exposure. So it's the second exposure. NSAIDs induce urticaria, angioedema. They call it now NIUA. A history of NSAID sensitivity is often is accompanied by asthma and rhinitis. Generalized reaction such as urticaria, wheals, angioneuritic edema, hypotension, shock, syncope, respiratory reaction such as rhinitis, asthma, nasal polyps, or both can occur. There's no reliable data on the incidence of anaphylaxis in the general population and no reports of its prevalence in palliative care units. However, because of the nature of the treatments offered at the hospice, it is likely to be very uncommon among these patients. I mean, generally speaking, we don't use a lot of NSAIDs in the palliative setting. So that's why we don't see a lot of these in the palliative care, but we see it in the outpatient pain clinics. Angioedema, the rash, the hives. So how you treat NSAIDs-induced urticaria / angioedema, or what we call NIUA? Epinephrine is the main treatment, and it should be given intramuscularly, not intravenously. And basically should be in the dilution of 1 to 1,000, not 1 into 10,000 like we do in IV for cardiac arrest. So basically, you take this ampule, which is 1 to 1,000, and you inject half of it IM. NSAIDs and GI toxicity. Well, we'll start with the gastropathy. GI toxicity is associated with NSAID therapy, such as gastritis, nausea, vomiting, diarrhea, gastric ulceration. Also, approximately 50% of subjects chronically using NSAIDs demonstrated, some degree of gastric mucosal dysfunction. Symptomatic ulcers and ulcer complications associated with the use of standard NSAIDs may occur in 1% of patients treated for 3 to 6 months, and in 2 to 4% of patients treated for 1 year. 80% of patients with GI toxicity have no preceding symptoms, and most have few or no risk factors. The incidence of upper GI ulcers is decreased by less than 50% with using selective COX-2 inhibitors, but remains above the background incidence of non-NSAID using population. As far as NSAIDs gastropathy goes, the risk factors are age over 70, a prior history of peptic ulcer disease, steroid use, alcohol use, multiple NSAID use, and a history of Helicobacter pylori. Prevention: antacids and cimetidine has limited success to be ineffective. Things that you can do is using PPIs, using sucralfate, misoprostol, but this is a drug that you have to avoid in pregnant ladies. Most of us use either selective COX-2 or we add a PPI. One of the things that's really undertaught in medicine here, the NSAIDs effect on small bowel and colon. NSAIDs effect on small bowel and colon, the distal small bowel and colon are susceptible to the deleterious effects of NSAIDs. The ileocecal region is a potential site for a variety of NSAID-induced injuries, including erosions, ulcers, strictures, perforation, and the formation of diaphragms, which can lead to bowel obstruction. NSAIDs can also lead to colitis, resembling inflammatory bowel disease, exacerbating pre-existing inflammatory bowel disease, or complicate diverticular disease. That means perforation or bleeding. So, in other words, NSAIDs can give you a picture similar to inflammatory bowel disease, or it can aggravate in a pre-existing condition. Patients with NSAID-induced colitis can present with bloody diarrhea, weight loss, iron deficiency, anemia, and sometimes abdominal pain. Older adults and those on long-term NSAID therapy appear to be at a higher risk. There might be an association between NSAID use and something called collagenous colitis. Colonoscopy may be normal or may show inflammation, ulceration, or diaphragm-like stricture. Histology often concludes nonspecific colitis. NSAIDs may cause perforation or bleeding of colonic diverticuli, may cause relapse to inflammatory bowel disease, and may exacerbate bleeding of colonic angiodysplasia. Treatment of NSAID-induced colitis should be discontinuing the medication or at least reduce the dose as much as you can. Sulfasalazine and metronidazole have successfully been used in few studies. Surgery is often indicated in case of life-threatening complications or intractable symptoms. Pathogenesis of NSAIDs-induced colitis is still controversial. Local and or systemic effect of NSAIDs on mucosal cells might lead to an increased intestinal permeability, which is a prerequisite for colitis. NSAIDs and bleeding. Bleeding time is consistently prolonged in individuals undergoing long-term treatment with standard NSAIDs. But the consensus there is that such prolongation is not excessive and that values remain below the upper limit of normal. The duration of elimination is related to the elimination half-life of the individual NSAIDs. Meta-analysis failed to demonstrate a meaningful increase in surgical bleeding in children using perioperative NSAID therapies undergoing tonsillectomies. However, intraoperative administration of NSAIDs, such as ketorolac, to subjects is not associated with an increase in surgical site bleeding, but it's associated with a small increase in GI ulcers. It is likely that previously reported high incidence of GI hemorrhage associated with ketorolac was a function of the excessively high doses used before. The manufacturers recommended a lower dose. This is very important, guys. So, in other words, ketorolac basically in smaller doses. I guess they're talking about the 15 milligram dose here. Should not increase the risk of bleeding, but it might increase the risk of GI ulcers. But it's not something major. Okay, this is the effect of NSAIDs on renal blood flow. As you know, with increased vasoconstrictors such as angiotensin II and catecholamine and vasopressin, patient treated with NSAIDs, actually will have more vasoconstriction because it inhibits the prostaglandin synthesis, leaving the action of vasoconstrictors unopposed. While if no treatment and no NSAIDs, prostaglandin synthesis is normally antagonizing the intracranial effect of the vasoconstrictors. So this is how NSAIDs are working, reducing the renal blood flow. NSAIDs renal toxicity. Renal impairment has been reported to occur as many as 18% of patients using ibuprofen, whereas in other studies, acute renal failure has been shown to occur in about 6% of patients using NSAIDs. Forms of renal impairment with NSAIDs include a reduction of renal perfusion due to inhibition of prostaglandin formation, acute interstitial nephritis, and nephrotic syndrome. NSAIDs and myocardial infarction. So NSAIDs in general can lead to increase in the thromboembolic complications, except aspirin, which is used as a protective medication and a secondary prevention for cardiovascular disease. So what are we taking from there? Well, you can add a small dose of aspirin, to the NSAID, if you're gonna use it on long term. Stevens-Johnson syndrome. This is a rare syndrome, but one of these days you might encounter it. And this is related to many drugs, including NSAIDs and paracetamol. And it's considered a medical emergency. Stevens-Johnson syndrome basically is a type of severe skin reaction with skin involvement less than 10%, together with toxic epidermal necrolysis with skin involvement more than 30%. And then you have the Stevens-Johnson toxic epidermal necrolysis overlap, which is 10 to 20 to 30%. All of these together form the spectrum of a disease called the Stevens-Johnson syndrome. Together with toxic epidermal necrolysis, SJS affect 1 to 2 people per million. So it's kind of pretty rare. and a typical onset is under the age of 30. So it's not, you're not going to see it a lot, but you have to be aware about it so you can pick it up early on, and you can save the patient life by doing so. Of course, these patients need to be sent to the ER and needs to be admitted and treated as a burn patient. Reye syndrome is a kind of an encephalopathy, with hepatic dysfunction that happens when the patient basically less than 16 years old, they taking aspirin, for viral disease. For some reason, they can develop an encephalopathy and hepatic dysfunction. So aspirin is contraindicated in young folks less than 16 years old. NSAIDs adverse effects. Again, we mentioned oxaprozine can show up as benzos. Diclofenac therapy is also rarely associated with optic neuritis and also liver dysfunction. Mefenamic acid can cause immune hemolytic anemia. Liver damage occurs with diclofenac and is usually reversible. Avoid aspirin in patients less than 16 years old and during breastfeeding because of increased risk in Reye syndrome. Indications of aspirin. Aspirin is used as an antipyretic, anti-inflammatory, as an analgesic in different conditions, such as migraine, tension headache, endomethacin-sensitive headaches, acute or intractable migraine, metastatic bone disease, joint disease, postoperative pain. Also for cardiovascular disease protection as a secondary prevention here. Also, NSAIDs are used as antipyretic. It reduces the temperature. Especially in palliative care, the antipyretic therapy has not demonstrated to prevent febrile seizures in children. Several studies have confirmed that increasing the dose of acetaminophen from moderate dose to a relatively higher dose in children failed to reduce the rate of recurrence of febrile seizures. So this is, this is back in children situation where you have children and febrile seizures. I want to say that these agents are commonly administered to hospital patients to enhance patient comfort. No studies have been done in the cancer population with fever, and carefully controlled efficacy studies have not quantified the degree to which antipyretic therapy enhances the comfort of febrile patients in other populations. So we've seen that we're using these antipyretics might help with comfort more or less in cancer patients. NSAID prescription. So I want to, point here some important practical tips. Okay, NSAIDs are contraindicated in for systemic use in severe hepatic impairment because of increased bioavailability and the high risk of precipitating GI bleeding and renal failure. Before prescribing NSAID, consider alternative treatment. For example, non-pharmacologic techniques or using a topical NSAID or paracetamol. Prescribe the lowest effective dose of NSAID for the shortest time necessary. Review response after 14 days. Discontinue if no improvement. Diclofenac, even in doses that's available over the counter, elevates the risk of cardiovascular toxicity. Other NSAIDs should be considered. In patients with the risk of cardiovascular toxicity, blood pressure, renal function should be assessed prior to and within 7 days of starting NSAID or COX-2 inhibitor, or after increasing the dose. All patients receiving long treatment with an NSAID COX-2 inhibitor should receive gastroprotective therapy, uh, such as a PPI, for example, or misoprostol. Okay, so in other words, NSAIDs are useful. Unfortunately, they have multiple side effects. So do not use them like forever. Use them for short term, achieve your goals with them, and then stop them. You have to monitor, the renal function, the liver function with these drugs, especially on long term. Avoid diclofenac because of cardiovascular toxicity. Try to use non-pharmacological agents. Try to use paracetamol. Try to use topical NSAIDs, which has less absorption, much less absorption than oral NSAIDs or IV NSAIDs, of course. Paracetamol. So again, as I said, paracetamol is an NSAID, but we keep it as a separate entity because it has different, properties, very, different than the rest of the NSAIDs. So I'm just giving you an example here of a drug called solpadine. Solpadine is basically constitutes three drugs together: paracetamol with codeine and caffeine. A very commonly used drug, for basically non-cancer pain. Paracetamol or acetaminophen is generally considered to be a weak inhibitor of prostaglandins working on the COX-2 inhibitors. But again, it doesn't work on the periphery, mainly central. And maybe this explains why it doesn't have a lot of anti-inflammatory effect. A dose of 650 milligram provide greater analgesia than doses of 325, but no extra analgesia is observed with doses above 1,000 milligram. This could indicate that 1,000 is the maximal efficacious dose. Acetaminophen is frequently combined with opioids to exploit its opioid-sparing effect. Paracetamol can cause hepatic damage secondary to glutathione depletion after overdose of APAP is minimized with an administration of N-acetylcysteine, especially within 8 hours after injection. Now, this is the antidote, acetylcysteine, N-acetylcysteine, for the acetaminophen overdose because it replenishes the glutathione. APAP or acetaminophen has near complete absorption and a peak of concentration 30 minutes to 1 hour after oral consumption. IV and rectal formulations are available and demonstrate similar kinetics. Paracetamol can cause transient hypotension upon starting the infusion. Be careful about this, especially in palliative setting where the patient is sick to begin with and he might be hypotensive. So it's just something that you need to know about. Once you start the IV paracetamol, you might have some hypotension. Acetaminophen metabolized by the 2E1 P450, basically to this toxic material called the NAPQI, and the glutathione basically in your liver detoxifies this toxin. So if you ingest a lot of acetaminophen, and you release a lot of this material, then you will basically consume the glutathione, and you will have liver dysfunction. So that's why you give N-acetylcysteine. Remember, this pathway is only 5% of the metabolic pathway of acetaminophen, which is basically either metabolized by glucuronidation or sulfate conjugation. Again, here, acetaminophen is metabolized in the liver 90% by glucuronidation and sulfate conjugation. 10% undergoes oxidative metabolism. It's not 5%, it's 10% that goes to form the NAPQI, through the CYP 450 system. Again, same picture here. Now, and basically, this is, how you deal with acetaminophen or paracetamol over, dosages. You have to pick it up within the first 8 hours and start immediately, and acetylcysteine. Codeine and caffeine in solpadeine has an adjuvant role to acetaminophen. Acetylsalicylic acid. Absorption of acetylsalicylic acid is rapid, both in stomach and small intestine. It's highly protein-bound and hepatically metabolized to salicylate. A history of salicylate sensitivity is often accompanied by asthma and nasal polyps, what we call the Samter triads. Parenteral NSAIDs. Basically, you have acetaminophen, comes in the IV form. Diclofenac comes in the IM form. Ibuprofen is a recent addition here. Can be given, we call it Coldalor, given IV, Lornoxicam, Piroxicam, Ketorolac, and Parecoxib Dynastat. Endomethacin sensitive headaches. This is important for the pain folks here, pain doctors. And you need to know these. All of the following are indications of endomethacins. Paroxysmal hemicrania, hemicrania continua, Valsalva-induced headaches, cough, sexual exercise, hypnic headaches, and this, patent ductus arteriosus. This is in children. Has nothing to do with pain, but something to know about. NSAIDs in pregnancy. Aspirin and other NSAIDs are not teratogenic at regular doses. However, NSAIDs are associated with narrowing of ductus arteriosus, possibly with gastroschisis and a decrease in fetal production of amniotic fluid. Additionally, the use of NSAIDs proximal to the time of delivery is associated with an increase in neonatal intracranial hemorrhage, and women are recommended against NSAID use during the 3rd trimester. Aspirin and other NSAIDs are Class D medications in the 3rd trimester, and Class B, or C in the first 2 trimesters. Acetaminophen is a Class B throughout the pregnancy. So NSAIDs and acetaminophen are generally considered safe while nursing. So this is the FDA classification for medications during a pregnancy. Here you have Class A, Class B, Class C, Class D, and X. So basically, we try to avoid NSAIDs in the 3rd trimester to prevent the problem with closing the patent ductus arteriosus. Acetaminophen is safe during the whole pregnancy because it's only class B during the whole pregnancy, first, second, and third trimester. So if you're dealing with any pain during pregnancy, you should start with paracetamol or acetaminophen. Again, side effects of NSAIDs during pregnancy here. Beneficial effects of inhibition of prostaglandins. Remember the 5 A's, contraindications, NSAIDs classification. So this is just like a mnemonic here. Diclofenac, as I said, we love these patches and the topical Voltaren here because it's much safer than NSAIDs. I want to say that there's a typical total systemic absorption of 3 to 6%, of the oral route. So when you put the topical diclofenac, in fact, you still have some absorption there, which is 3 to 6%. It's not significant, but something to consider. If you're using a huge amount of topical, you might get some systemic toxicity. Menthol is another agent topical we use, and we usually add it to methyl salicylate. Menthol work on TRP MA channels. Capsaicin, it's not a typical NSAID. I just put it here for comparison. Capsaicin 8%, and this one works on the TRPV1. Again, it has an anti-inflammatory role, and we use it in osteoarthritis, and we use the Qutenza or the 8% patch for shingles, for post-herpetic neuralgia. Okay, we're going to end our lecture with, with colchicine. Colchicine is a very interesting medication. It's coming out of this, plant called Colchicine autominal. I hope I'm pronouncing it right here, but it's ancient it's available from ancient time here in this area between the Black Sea and Iberia and Armenia. So this is a kind of a traditional drug, basically. We have the 0.6 and 0.5 milligram of this drug. Colchicine is a very old drug, or that basically originates from plants, and its first use has been described in rheumatic complaints and mentioned in old Egyptian medical papyrus, Eber's papyrus dating back to 1550 BC. However, the active compound, tricyclic alkaloid, was first reported in 1955, and its name was derived from Colchis, which is an ancient region close to the Black Sea, where the plants of colchicum were widespread. In 2009, US FDA approved its use in familial Mediterranean fever, prevention and treatment of gouty attacks, acute pericarditis, and recently in cardiovascular disease secondary prevention. Colchicine side effects include abdominal cramps, diarrhea, bloating, and a small risk of trisomy if it's taken at the time of conception. So most of the people that takes colchicine, they get some GI side effect. And this is the main side effect of this drug, and probably those who stop it is usually related to the GI, abdominal cramps, and diarrhea. Colchicine, again, a mechanism of action. It inhibits the tubulin polymerization, inhibiting the cell migration, adhesion, reduced release of pro-inflammatory cytokines. So it's an anti-inflammatory drug. But I mean, interestingly, colchicine doesn't have a role in osteoarthritis. Maybe because osteoarthritis is more of a degenerative joint disease than it's an inflammatory joint disease. Now, we have recent evidence that colchicine has a role in secondary cardiovascular disease prevention. Again, the only problem with this is it interacts, with some of the cardiac medications here. Again, the mechanism of colchicine. And this is for colchicine for acute attacks and also as a prophylaxis for gout flares. So, as far as gout concerned, it's used, for prevention and treatment at the same time. Key learning points. All non-steroidals are associated with renal adverse effects in addition to cardiovascular and gastrointestinal GI toxicity. Topical administration provides an alternative route that reduces the risk associated with systemic NSAIDs. NSAIDs are contraindicated for use in severe hepatic impairment because of increased bioavailability and the high risk of precipitating GI bleeding and renal failure. Diclofenac, even in doses available over the counter, elevates the risk of cardiovascular toxicity. Other NSAIDs should be considered. Celecoxib has a superior safety profile compared with other NSAIDs, while proving to be non-inferior to naproxen or ibuprofen in terms of cardiovascular safety. Higher doses of celecoxib, more than 200 milligram, will attenuate this cardiovascular benefit. Thank you.